Hello and welcome to today's webinar, Let's Talk Telehealth. This is presented to you by Aegis Therapies. My name is Shawn Blakely and I'm a physical therapist and AVP with Aegis Therapies, and I'm looking forward today to facilitating today's panel discussion. We're going to spend the next hour or so hearing from a group of therapists that are actively engaged in telehealth. Telehealth or telemedicine, as some may know it, is not a new treatment mode. In fact, telehealth has been used since the early 60s, and it's expanded exponentially in the last decade as technology has improved. And of course, with COVID and the pandemic, telehealth has become more prevalent, and in some instances is actually necessary in order for us to provide care. Many clinicians are becoming more familiar with the practical realities of providing telehealth in the field. And we hope that the information provided today and the experiences that are shared by the panelists can give you the information that you need to get started with telehealth. Just let the panel know what your questions are. You can type your questions right into the chat feature, and our coordinator, Shyla, will be helping me out today by chiming in periodically with your specific questions. If you have a question that's specific for a discipline or a specific panel member, please indicate that in your question. So let's go ahead and get started. We're going to let the panelists introduce themselves, and we'll begin with Ryan.
Hello, my name is Ryan Loucks. I'm a speech-language pathologist. I've been working for Aegis for about 12 years in Northwest Indiana. I began doing telehealth at the beginning of the pandemic under emergency measures, and I continue to do so. In fact, I'm doing some on Friday.
Very good. And next up is Stephanie.
Hi, my name is Stephanie Schild. I'm an occupational therapist. I have been with Aegis Therapies for 20 years, I believe it is now. Just like Ryan, I've been doing telehealth since we got the approval to start doing telehealth in post-acute care, and am actively doing telehealth just like Ryan this week. So looking forward to sharing our experiences with you all.
And last but not least, Miss Janice.
Hi, I'm Janice Brown, physical therapist with about 30 years of experience in geriatrics. I've been with Aegis Therapies for 28 years in January. I serve as the clinical practice specialist for Aegis for facilities in Virginia, Kentucky, and Southern Illinois. And as part of helping out with coverage, I've done telehealth since the pandemic started.
All right, guys, thank you for those introductions. And we're going to kick things off today with Stephanie. Stephanie, our first question is, what is the difference between telehealth and just providing a treatment in person?
So when I think of telehealth, it is really synonymous with an in-person treatment. There really should be nothing, quote unquote, different when we're providing telehealth services. If we're billing for telehealth services, it's just as if we're doing in-person treatment, we need to make sure that those services are skilled and justified. And I think the thing that sometimes people forget when we're doing telehealth that maybe makes them feel like it's different than in person, we have to remember about that whole clinical analysis that we're doing. Anybody can walk a patient, help a patient get dressed, but when we're doing those things, we're doing a lot of clinical analysis about what's going on and making modifications. And so we're just implementing those things through a different mode of delivery, telehealth versus in person. And then obviously there are going to be a few things that won't work in telehealth. So doing like joint mobilizations, there are certain treatment interventions and strategies that will only elude themselves to in-person treatment.
Mm-hmm. Makes sense. Janice, who can do telehealth?
Well, currently, telehealth can be provided by physical therapists and occupational therapists and their assistants who are under appropriate supervision, of course, as well as speech-language pathologists. Now, I want to point out that it's really imperative that you examine your state's licensure law and the licensure board regulations and rules. In many states, the State Practice Act is actually silent on the use of telehealth. And if that's the case in your state, I would recommend contacting your state licensure board to ensure that there are no limitations or restrictions for practicing telehealth.
I'm sure there's some specific requirements in order to do telehealth. Stephanie, maybe you can expand on what those requirements are? You might be muted
Sorry,
there.
I think I was muted. Just keeping in mind, like you mentioned at the very beginning, telehealth has been around for a long time. For those of us practicing in post-acute care, this is something that's a little bit newer. So I'm going to speak specifically to CMS and in the post-acute care setting. First and foremost, we want to make sure we check with the payer to make sure that telehealth is an allowable billable procedure. For CMS, thankfully it is. And then we need to make sure that we're using asynchronous communication so that we have that virtual two-way audio video communication. There are some telehealth experiences that don't require that, but for billing purposes under CMS, we need that two-way video and audio communication between the patient and the therapist. We also need to make sure that we have informed consent before we proceed with telehealth, and if that is either with the patient, the power of attorney, or power of healthcare, we need to make sure we're doing that. And then last but not least, it's important that you check with your State Practice Act. In some states, you do only need to be licensed in the state where the patient is. So for me, I reside in the state of South Dakota. I'm able to provide telehealth services to patients in the state of Oregon, maintaining my Oregon licensure. But there are some states where you do need to actually physically be located in the same state as a patient, but not necessarily in the same location. So just as Janice mentioned earlier, it's super important that you check your State Practice Act to make sure that there are no any additional requirements, including some states also require that you have written consent from the patient and not just verbal consent.
Mm-hmm. And I know with COVID, there's been so many different platforms that we've all gotten used to. Janice, are there specific platforms that we can use for telehealth specifically?
Yeah, right now, per the Department of Health and Human Services, during the COVID-19 nationwide public health emergency, they were much more lax than previously with telehealth. A covered healthcare provider that wants to use audio video communication technology to provide telehealth to patients, they can use any non-public facing remote communication product that's available to communicate with patients. So an example of a public facing would be something like Facebook Live, which I can't imagine why you would want to use that, but that is not acceptable. Some acceptable examples are FaceTime, Zoom, Skype, Doxy.me, Microsoft Teams, and I'm sure there's a ton of others, but they can be used during the PHE. The key is to maintain as much privacy as possible, just like we do when we do in-person treatment. You want to avoid individuals other than the patient or the caregiver being in the frame, and also within audio distance, which can be difficult in a SNF for sure. But those are the main things that you want to avoid. The allowed platforms after the PHE ends will probably change to more Doxy.me and Microsoft Teams, that kind of thing. That's a little bit more HIPAA secure.
Mm-hmm. So there's people on both ends of the camera, and it just seems like maybe the documentation for this would be a little bit different. Maybe Stephanie can speak a little bit to how does the documentation work for telehealth?
So when we're documenting for when we're providing telehealth, it really is no different than any other documentation that we're doing, whether it's our daily notes or our progress notes. The one caveat to that is noting that you are doing telehealth for that particular CPT code, and then making sure that we're documenting about that informed consent and that the patient has consented to that treatment session. Again, as I mentioned earlier, some states do require an actual physical written documentation be placed in the medical record, and then that one allows you to proceed with telehealth throughout that episode of care. If your state doesn't require that, simply going to ask that patient at each session if they consent to receiving those services via telehealth, and then just putting that in your daily note. And again, just as we do any other time, we're documenting about what was skilled that we do. For myself personally, because each of my sessions does have a helper or quote unquote assistant with the patient to maintain safety and help facilitate that treatment. I always acknowledge what discipline or if it was a CNA, director of nursing, who was in the room with that patient assisting as well.
Very good. Well, Ryan, let's bring you into this just a little bit. You know, if I'm out here in the field and I want to put together some processes and I'm thinking about trying telehealth, what do you think would be important for me to know?
I think for me personally, and given my experience with this, consistency and predictability, particularly with regard to the helper, is vital to keeping everything running smoothly. So I begin and do every therapy day the exact same way. I start by reading notes, especially if I know that there's a patient who has potential for aspiration. Again, I'm a speech language pathologist, so these are the things I'm looking for. The second thing I would do is provide the helper with all the materials that I may need. I work out of the state of Indiana, and I perform a lot of mandatory tests, the BIMS, PHQ-9s. These all have to be submitted to our customers. So I make sure that my helper has copies of those so that they can assist me in the administration of those tests. The third thing I do is stop by nurses' stations. Oftentimes, speech language pathologists visit with nurses as they go down a hall. When you're doing telehealth, you don't have that opportunity. And our customers often miss that I've ever been there. So we stop by, we talk to the nurses, make sure the nurses don't have anything verbally that they need to tell the speech language pathologist. Number four, I perform the treatment. I usually ask the helper to design a path that is the most efficient way to go about it. So we'll just go room to room to room. Typically, this is 15-minute treatments or 30-minute treatments, which makes bringing them down to a therapy gym that's already crowded a little bit difficult. Fifth step, we return back to the therapy gym. This is also often a person that is not my DOR, but I ask to speak to that person, give them the information that I have accumulated, any grievances, any changes of diet, and they often will then communicate that to the facility. Again, when I perform telehealth, it's usually as an emergency measure when a facility loses their speech language pathologist, and I'm simply filling in. This is not my long-term caseload, so I try to make it as seamless and painless as possible for the facility.
Mm-hmm. I know in my area it's been similar, where telehealth has not been intended to replace in-person treatments, but in these instances where the only other option is for someone to go without care, telehealth has really been a lifesaver. Janice, what about you? Did you want to comment or chime in just a little bit on what you think would be important?
Well, I just know that I wish I would have known better how to plan ahead. Just like Ryan was saying, to eliminate wasted time and be as thorough as possible for everybody involved. And also think outside of the box for the most appropriate helper. It may be that if I'm doing an evaluation and the OT's doing an evaluation the same day, that may be the most appropriate person to be my helper during my portion of the evaluation. So just those kind of things, really think outside the box and be creative when you're developing your processes and streamline them.
Mm-hmm. So you guys have mentioned the helper. So, you know, the way I've seen this done is that I, as the therapist, I'm on one side, and the patient has somebody else with them on the other end. Who do you get to facilitate that? Like, who is this helper, or who do you think it should be? Who can it be? And maybe Ryan, we have you start kind of speaking to that just a little bit.
So again, I work in the state of Indiana. We don't have speech language pathology assistants here. So for me, has almost possibly every single time it's been a PTA or a CODA. This has been interesting because I've gotten to work with PTAs and CODAs in a way that I never have before. Typically, I have asked the DOR, who do you think is the person that I'm going to be able to mesh with the best and who is most amenable to the whole process? And it typically is the same person in each building every time. So I have generally requested that the DOR pick that person.
Mm-hmm. Stephanie, what about you? Yeah, no, that's perfect. It's helpful. I know we all have different processes. Do you do the similar thing, Stephanie, or something different?
Yeah, I think kind of back to the prior question that was asked about processes, as the three of us panelists were discussing, we each handle things a little bit differently. Our disciplines are a little bit unique in our approach and how we handle telehealth. For me, the helper that I have usually is, I would say the majority of the time, is a COTA. And the reason that I gravitate towards having the COTA there is because it allows me an opportunity to collaborate with them. So if I'm doing an evaluation, it allows that COTA, myself, and the patient to do some collaboration. Sometimes we have nursing involved, and maybe they're in the room as well. So I've had some great conversations with facility staff during our sessions. But that's usually who I choose. Once in a while, I do have the PT or the PTA there. And it's great because then we're able to do a little bit of interdisciplinary collaboration. And I think since COVID came about, a lot of times in facilities, therapists have worked in silos, even though they're in the same facility because of some of the restrictions. Everybody's not eating in the same space or in maybe the office together. So it's allowed for some really good collaboration time with the PT, the PTA.
Hey guys, we have a question.
Yeah.
We have a question that says, I'm a physical therapist. If I have the OT as the helper while OT is completing their eval as well, can both PT and OT bill eval at the same time like a co-treatment?
Oh, I was ready for that one. I just answered this yesterday. It would be the same as if you were doing the evaluation with PT and OT in the same room. You would, well, pretty much, you would not bill the exact same time for all of it. The OT would not bill the time that they're being the helper for the PT, if that makes sense. That's probably the simplest way to say it. Now, that's not to say that the OT is not going to make some sort of observation during that time, but the helper time cannot be billed the same as the person providing the service.
I think, Janice, you said it point blankly. What we do during telehealth, we don't bill or treat our clinical service any different than we do in person. So if we're going to be billing for that time, we need to be providing a skilled service at that point in time. And then just one additional thing, Shawn, I wanted to backtrack about, we talked about the helper. I think it's really important for folks to understand that telehealth does not require anybody to be present with the patient. I do work with some speech therapists who have worked on cognition with patients, and they've maybe had a facility representative or another clinician go in and set up the tablet or the laptop, help with getting things connected. But then that therapist was able to facilitate that telehealth session with the patient. So again, there is nobody required to be there with the patient during a telehealth session. We all talk about having a helper there because, for patient safety, for a lot of the folks that we're working with in post-acute care, needing that extra set of hands, that's why we're choosing to do that.
Mm-hmm.
I have another question if you're ready.
Yeah.
This is, hi, you were saying earlier that there are two things we need in every skilled note: the patient consent about telehealth, and what was the other requirement?
I put in my note, if somebody was there helping, I'll note that the COTA was present and assisting with that telehealth session. I've had a director of nursing in there, so then I just made a note that the director of nursing was in there assisting with that session.
Okay, and then can you use a non-skilled person as a helper?
Absolutely. The biggest takeaway there is if you are going to use a helper, making sure that you as the clinician are comfortable with that helper being there, number one. Number two, that the helper feels competent and that they're able to be there and facilitate, the assisting of that service delivery. And then the third one, just making sure the patient is okay with that individual being in there. And I think, Ryan and Janice can chime in as well, but I can't even tell you how many telehealth sessions I've delivered over the past, 2 years. But I think only once had somebody that was questionable or maybe not wanting to do their visit telehealth. But otherwise, all of my patients have been more than receptive. Actually, some of them have been very excited about doing the telehealth session, especially during the pandemic. Because here's the thing, and I think we're going to talk about this later, but it's good timing. As everybody's walking around a facility in a face mask during the pandemic, I was the only human being that they were actually able to see. My face, my expression, my lips move, so it was a completely different experience for some of those clients that I was working with, and a fantastic one at that.
Oh, and Stephanie, I agree completely. I even had a patient say, "Oh, look, I can see her pretty smiling face." And so, I mean, my experience has been so positive with this. Occasionally, you may have somebody that's a little hard of hearing, and that's kind of difficult. But sometimes we can actually adjust the volume, and we've even used headphones before to help with that. And as far as the helper goes, I've used PTAs and CODAs as well. And I concur with everything that Stephanie said in regard to that. There are benefits to both of those. I just think if you're using like a rehab tech or a rehab specialist, from a PT standpoint, you need to look ahead of time and determine if that's really going to be appropriate. How complicated is this patient, and is it really going to require the skills of probably a PTA to be in there with you, especially if there's palpation involved in that kind of thing. So it's really a judgment call, but you have to prep ahead of time before it's too late.
Shyla, any other questions right now in the chat?
Not at this time.
Okay. Does the panel have any more comments that they want to make on process questions before we move on to the ethics part of this?
One of the things I just wanted to comment on the processes, we all do things slightly differently. It doesn't mean it's wrong necessarily to do things differently in your approach. And the other thing I would say, telehealth, if you haven't done it before, it's one of those things that you kind of just need to dive in. Speaking for myself, I didn't have any guidance when starting out to do telehealth. Telehealth was approved, and we were without an OTR, and we had patients that needed care. And it was like, Stephanie, figure this out. So you kind of have to sometimes blaze your own trail. And the one thing I would say is, be patient about things when they don't go the way that you want them to go during that session. I've even had to talk a couple of folks off a wall before when things were going amok. Maybe the technology wasn't working right. My sister and I have been very savvy to switch between DoxyMe. She's in a very rural area and loses connectivity. We switch between DoxyMe to Teams, and we may switch to Google Duo, all during a singular telehealth visit, and then have to use our phone for audio. So it's learning about those processes. And the more you do telehealth, you will work on being able to streamline your processes and approach. And I think about it just like, remember back when you very first started treating a patient, you didn't know everything. But each day that you went in and treated a patient, you learned more, you grew, you became more efficient. Telehealth is really the same way. It's new for all of us. So we're kind of creating those systems and processes. So again, be patient if things don't go well, because they won't. They will not go seemingly perfect the first or the second time, but you'll learn how to adapt, because therapists are amazing adapters, and you'll figure out things that will work to help you function more efficiently while still providing quality care.
No, that's good advice. What do you think about the ethics of this? What would you say to somebody that would say, well, this isn't ethical? Therapists should be there in person to treat their patients. I'd love for each of you to kind of chime in just on what you've heard or what your thoughts are about that. And Stephanie, we could start with you.
Okay, so for me as an OT, the thing that I would point out to all of my OT friends out there is our good friends at AOTA have a plethora of information on their website, specifically one addressing ethics, and there's the position statement. And what I would want everybody to know is key into the dates that those articles are written. They are written before the pandemic. So, you know, the ethics issue and concern, while it is real, it's been addressed. And so the things that we need to be mindful of when it comes to ethics are the same things that we have to be mindful when we're providing in-person treatment. Making sure, again, that the patient's comfortable with that session, that the person helping is able to do it, that you're making good choices for standardized tests and measures. And believe it or not, in the AOTA position statement, they talk about standardized tests that are evidence-based for telehealth. So that's a pretty fantastic thing for our association to have looked into. You know, and then on the flip side, when you were talking about, you know, is it ethical to do telehealth and, you know, is in-person better? Obviously, in-person treatment is always going to be beneficial. But during these times, we really have to make a decision between sometimes a patient getting services and no services at all. And I think my colleagues on the panel can agree, getting a patient therapy services at the right point in time is very critical into their quality of care and their rehab. And if it means the only way to do that is via telehealth, something is better than nothing at all, as long as we are providing good services, skilled services, and sticking to those standards and practices.
Mm-hmm. Janice, let me give you a second to chime in on this.
Well, I agree with everything that she said, and the APTA stance is that it's all about increased access to our services. Even before the PHE, we have, you know, a staffing crisis, and we've never been able to meet the needs of a rural environment today. So the APTA, you know, long before the PHE, was strongly supporting legislative and regulatory changes, such as the expanded Telehealth Access Act. And that would permit PTs and PTAs to provide services via telehealth. It's a bill that permanently lists PTs and PTAs as authorized practitioners under the Medicare program. So, you know, like Stephanie said, with AOTA, this was talked about long before COVID hit. And it's all about access to patients and getting patients what they need.
Mm-hmm. Ryan, what would you add?
I'll add a story. Within the first couple of weeks of doing telehealth, I had these thoughts and received at least 3 referrals in a single week for patients who had just recently got a new tracheostomy and who were on feeding tubes. And a director of nursing came to the room. There was a PTA in the room, a bunch of CNAs. And I realized, though I wasn't in the room, I was the single most qualified person in that room. Everybody was intimidated by I was intimidated. I said, I can't do this. But after the third one, I started getting used to it and started to value myself a little bit more in that context. We sometimes, I think, as therapists, downplay our expertise and the skills that we have because they become so commonplace to us. We forget that we have talents that others don't. And I enjoy being in that room now possibly even more than actually being in the room, because I get to sit back and watch everybody do what they're doing. And then, I don't know, I'm kind of the director. And I appreciate that particular element of telehealth.
Mm-hmm. Yeah, I know sometimes people that, oh, Shyla, you've got a question?
Yes, we've got several lined up.
Okay, good.
I'll just start at the top. How to bill when OT and PT do a co-eval. One of the therapists is on telehealth and the other would be with the patient. Number 2, this is all in one. She has several questions in one. The second part of the question is, how often can a patient get telehealth sessions? are there limitations on sessions? And 3, how to bill if there is a connection error where a gap of 10 to 15 minutes within sessions?
Good
I'm happy to
questions.
take that question.
All 3 of them or just one?
Well, I mean, I remember definitely the billing piece. But so as far as the billing goes, if there is a helper there, so again, I'm myself as the OTR and my COTA is assisting on the far end. Again, only one person can bill for therapy services. So we have to keep in mind, the person that is helping the patient, it's not requiring any skilled intervention. So as we mentioned earlier, anybody can be with that patient. It could be a family member there. So the person with the patient is just strictly my hands helping facilitate and assist. So I am doing the billing during that telehealth visit. The helper is merely there. And for those of you that are in facilities where you're concerned about productivity and efficiency, yes, that is essentially some downtime for that individual. But again, that 15, 25 minutes of downtime for that person to get the services that they need, for me, it is, doesn't exist. But as far as billing itself goes, you're going to bill for the same CPT codes that you would bill for an in-person treatment based upon the services that you're providing. And then you're going to add on the 95 modifier for telehealth. So if a lot of you are using, an EMR system, a lot of those things are built in to add that telehealth modifier. Janice, do you want to take the rest of that question?
Well, now I've forgotten what they were. What was the second one, Shyla?
The second one was, how often can a patient get telehealth sessions? And are there limitations on the sessions?
Yeah, you give me that one, Stephanie. To my knowledge, there are not limitations unless there's something state specific. So do your due diligence and, talk with your state board, which is probably the best idea because sometimes it's hard to get through all the paperwork and find what you're looking for. But definitely check. But does anybody else on the panel, have you ever heard of any limitations on how many?
No, I think the biggest limitation, kind of as you mentioned, comes down to the Practice Act. I know a lot of folks try to tee up and tie in their telehealth visit with the supervisory visit. There are some limitations in certain states with that. So again, it's very state specific. But if you want to, like we've had patients during, when they've been on isolation and quarantine for COVID, for example, who have had only maybe there's a PTA in the locked unit and there wasn't an OT allowed in the locked COVID unit because of a customer's restrictions. And the OT was able to provide all of those services via telehealth. It might be 30 visits a week. It might have been 4, might have been 5. There's no restriction. So again, it really all comes down to your clinical judgment about what is going to be the most appropriate therapy session for that patient. And again, obviously, we would love to get our hands on each and every single patient, but in today's world, the opportunity isn't always available for us.
And Shyla, what was that third question?
The third was how to bill when OT and PT do a co-eval.
Okay,
one therapist is on telehealth and the other would be with the patient.
Right, and Stephanie pretty much answered that. The easiest way for me to think about it is if the OT is doing OT things, OT assessment, they can bill. But if they are the helper and, they wouldn't normally bill for PT, so they wouldn't bill that.
Okay. Next question. I did an evaluation during COVID. I had anxiety that I would miss something important during the eval after completing the assessments, and I was not comfortable. What should I do in such situations?
Oh man, that was everybody. I'm sure it was Ryan and Stephanie, and I did miss things. And I had to call the PTA and say, will you run down there and measure this because I forgot to get it. we're all going to do that, and you just have to follow up and get the information that you need. I mean, what do you guys think? It's so common.
You know, I would say it probably took me a year of practice to stop doing that with in-person evaluations as well. And when we're dealing with scopes of practice as broad as speech language pathology, we don't capture everything in day one. That's just not possible. So that's why communication with the helper is great. When we have our little brief meeting before we start our telehealth sessions, they will give me an update. Hey, guess what happened? What happened? I wasn't aware of that. Yeah, we forgot to check on swallowing pills. Apparently, the patient was having difficulty swallowing pills. The nurse just told us. This is why that communication is very important. But I wouldn't say that it's that distinct from in-person evaluations.
I would totally agree with Ryan. And I think sometimes we may become a little more judgmental and critical of ourselves as therapists when we miss things. But hey, we are all going to miss things at times. And it doesn't mean we did a bad thing or we did something wrong. You heard me say earlier, give yourself grace, be patient. And during the telehealth eval, and I think, I'm guessing, Ryan and Janice, you have changed your flow in how you do a telehealth eval today as compared to the very first one, right?
Yes, yes.
as Ryan's eyes are rolling. Yeah. So you learn how to be more efficient. What are the most critical areas to hit on during an OT eval? Like, I have learned how to pull in multiple measures into one simple task with a patient. So again, it's about learning. This is a learning moment for all of us, how to be efficient. And if you miss something, as Janice said, go back and ask a colleague, or if you have to, pop in for another telehealth check-in the next day or 2 days later. It's okay. It's totally okay.
Well, and a process that I think helped me is when I had to jump in right away and do that, I didn't do any of the prep work. I didn't have access to PCC to have the information ahead of time to know the helper, to know what to tell the helper to take with them. So once you start doing this, you're going to know what you want your helper to take. I'll be like, you need everything to take vitals, your gait belt, a goniometer, and so on and so on. So I really think being prepared, and make sure that you ask for some paperwork so you know what you're dealing with ahead of time. If I know that I've got a cardiorespiratory patient, the assessments that I'm going to have lined up on my desk are going to be different than if I have an ortho patient, right? So it's important to at least find out what their diagnosis is, what they're there for, so you can be more prepared then.
Yep. And I will say, even at that, be prepared to walk in, feeling prepared, and that patient is not going to present how you anticipated, and things are going to shift, and you're going to have to adapt. And that's the beauty of therapists. Therapists are so good at adapting. So just be prepared for that.
Awesome. Okay. Have another one. What happened to modifiers which we were using for telehealth in Kasamba?
The modifiers are still the same. It's still a 95 modifier. If you happen to be someone that switched from Kasamba to NetHealth, we choose E-synchronous, not E-asynchronous. Asynchronous means not at the same time, as in recorded, probably. But when you choose that, it just does the behind the scenes work of putting the 95 modifier in. So I hope that was the thought behind that question.
Okay. If a patient falls while the helper is assisting with transfers, ambulation, who's responsible for his fall?
Well, I've had it happen. Do you want me to take it? It's an accident unless it was gross negligence. So with my particular case, the person it typically does very well. They just had a dizzy spell, but we were using a gait belt and the patient was lowered to the floor. So just like when you're in the facility, it's nobody's fault. It was a patient incident. Again, unless there's gross negligence. But that's why you want to, of course, for ambulation, be utilizing the gait belt. Do you guys have anything to add?
No, I think it's just like in person. As long as you're following your, all is well. Things are going to happen, you know. And again, it's about just following proper policies and procedures.
Mhm.
Okay. Do y'all want to go on to some more questions, or do y'all have other things to cover? Which,
If you've got some more questions, Shyla, let's hear them.
okay,
These are great questions.
okay. Could you tell us about patient candidacy criteria? A lot of our patients in SNF have dementia, HOH, or people with vision issues. Are they appropriate for telehealth?
It's a good question.
I think I can speak to that one. Quite often, as I said before, I may be the only person as the speech language pathologist to treat this particular issue. But when it comes to cognition, it is not uncommon for me to do the evaluation and say, I just didn't think this was working. The patient maybe doesn't like those phone things or whatever it is, and I will refer to the OT. If it seems as though in-person treatment by an OT would be a better option for the patient than telehealth treatments by me, then I will make that recommendation. It's also not uncommon for me to do the swallowing component of the plan of care and then pass the cognition component over to the OT. Each individual evaluation presents differently, and so we just make a choice. And this is where the helper comes in. Oftentimes, the helper that I'm working with has been with the facility for quite a while. They know the patients. Sometimes they can tell me right up front, this patient has never wanted to work with a speech language pathologist, much less over the phone. We know this, so then we don't pick them up. I don't think it's that distinct from how to determine whether somebody's appropriate in person.
Well, and in my experience, I actually turn into a small TV with a woman on there that the patient, I don't think really cares one way or another. We had to get consent from the responsible party because of their cognition. But I was able to direct, in that case, that was a good time that I had a PTA because I could direct them in what I wanted to see the patient do instead of directing the patient directly. So I've been able to make it work even if they can't hear or see me, as long as I have that good helper there.
Mhm.
What about you,
And
Stephanie?
yeah, we adapt the same way as in person. You know, it might be a patient that needs to communicate via the whiteboard. So then it's me asking the question and my helper writing it down. A lot the patient may verbally answer. I can hear them. You know, so I would say out of all the visits that I have done, there have only been 2 times that I have questioned telehealth being appropriate. One of them was a situation, unbeknownst to me, the individual had multiple psych issues, and I was perceived as being somebody that was spying on him, and it created a ton of anxiety and whatnot. You know, we didn't know this about that individual, so obviously that patient's care, we had to make some adjustments and move away, find some other solutions other than telehealth, because we certainly didn't want to exacerbate that. And then I had one other situation where an individual just didn't want any part of it. So I would say that the times that I have found telehealth not to be appropriate have been minuscule.
We need to make sure that we as therapists and clinicians are not the inhibiting factor. That if there really is an inhibiting factor, it's the patient and not us. We have to be flexible, just like we've talked about.
Excellent point, Janice.
Okay. Another question, I do a lot of unbillable notes such as PN and research remotely for a couple facilities, and they have not had an in-person PT for several months. Is there anything I need to do to document in the notes to show I was not present and just doing the notes by reading through daily notes?
Okay, so that's, oh, you can't ask them. I was wondering, so they haven't visually done a session with the patient? Is that what it sounds like?
That's
I think
what
it sounds like
like.
it's all telehealth, like the soup visits, I'm guessing the R visit
Okay.
is all telehealth.
Yeah, that's a little concerning. Stephanie, I'll let you take that one.
Thanks, Janice. So this brings up a really, really critical point, and it's a very big passion point of mine. It comes down to supervision. So I think the piece to keep in mind, again, if we are doing telehealth, remotely, whether it be to pinch hit or it being a little bit more of a semi-permanent thing because of staffing, we need to remember there's still a supervisory component that needs to happen to meet CMS regulations and to meet state requirements. So that would be the thing that I would encourage, is maybe a little bit more dialogue and conversation with the assistant about those patients. Obviously, at some point in time, all of us as registered therapists are doing non-point of service documentation, particularly in the situation of an unplanned discharge. And you're doing that based upon the documentation. But my recommendation would be to try to integrate some component of supervision, if at all possible, with the same said discipline.
Yeah, I mean, I totally agree. We've all had to do it in certain cases, but that should be the exception rather than the rule. And I would just personally ask and say, I need to lay eyes on this person, even if it's using a platform and not in person.
Okay. Do we bill for the actual video audio call under eval or under any of the any other treatment codes?
Just like you build just like you do in person, like Stephanie, I think you said that earlier. So
Okay.
use the same ones as if you were doing it in person, you would bill the same way.
Yeah. And I think going back, there was the prior question that asked about if you lose connectivity and billing, and I don't think we touched on that. So in those situations where we do lose connectivity, if there's like some dead time, that's going to be non-billable time. I just personally, for me, I have a little notebook at my desk when I do telehealth visits, and particularly when it's my assistant that's a CODA, I verbalize to her, I'm starting this patient session at 9:55, and maybe I'm doing an evaluation, and I write all that stuff down. Like, I keep track of it. And then I tell her, you know what, I'm going to clock out now at 10:10 from this eval, because then a lot of times my assistant may start or finish treatment with that particular patient. But if we have a down dead time where we don't have that connectivity of both audio and video, that time would not be billable. Now, we have had times where we've lost video connectivity and we could not get the video connectivity back. The only thing that we had was an audio connection by the phone. And, we could just throw our hands up and be really super frustrated. But what we've done is we capitalize on that time where she's maybe providing the treatment with the patient, and I'm able to ask her to do something. She's doing it, but she's doing the billing for all those things with the patient. I'm just kind of asking questions about things. She's maybe checking something, but because she's there actually physically providing the service, it would be no different than if we were in the therapy gym and she was working with that patient. I said, hey, can you check on this, or can you do that task with that patient? It would really be no different.
Okay. where or how do you distribute the downtime for the prep documentation review prior to a telehealth session?
Well, I mean, it would definitely be in non-patient care time, and it would depend on, even if everybody uses NetHealth, you may have different buckets for your time depending on the company that you work for. So, I mean, like Ryan, where do you put your rep time? What's it, your prep time? Like, do you put it under documentation in the non-patient care time?
It depends. I will break it down, but I would say that I apply the exact same strategies that I would to in-person treatments. But it doesn't take that long. Reading
Right.
through a patient's notes real quickly takes you 2 minutes. It's not something that's really all that prohibitive. And I actually, if I don't have time to do it before the session, there is plenty of time where my helper is manipulating the patient and I'm reading through those notes as we're doing it, which is, yeah, we'll probably get to that a little bit later on. So I would distribute the exact same way.
I'm going to go back to the question before it, and he followed up with, they do have a supervising PT in person once a week, but they can't do all the notes. So the supervising PT is there in person for the required per state practice act. However, they can't do all the progress notes and research, if that makes sense.
I would still, just personally, I would still ask for a 15-minute telehealth session if I'm going to write that note, if it's on a consistent basis. A one-time thing, that would be a little different. I could go from the PTA's note, but if I'm doing that consistently, I still want to see them 15 minutes.
And that's when it's great. This is when telehealth can be a huge bonus, guys, because I just, want you to think about when you're working in a facility in person, how often are you collaborating with your assistant about all the patients that are on your caseload? Are we doing that? So for me, this is like it is a true blessing in telehealth for me to have that time with the patient and my COTA. So maybe it's 15 minutes of downtime for her, but I'm able to ask questions about all of the goals. I'm able to ask the patient how they feel this particular goal is and validate with the assistant how they're performing. So look for some of those opportunities to, kind of be all inclusive on that telehealth visit and capitalize on it and use it as most efficiently and effectively as you can.
And that's an excellent time to make sure that the assistant knows the treatment techniques that you want used with this patient, because you can't guarantee everyone's competency. Maybe they're not familiar with chest physiotherapy or increasing flexibility of the chest wall. So that's a great time that you can show them exactly what exercise you want done or manipulation or whatever.
Okay. How legit is it to use telehealth as a replacement for a therapist, as certain facilities has no therapist for a long time?
I
Well,
think I take the word legit out.
Yeah, because seriously, I can think of a facility that we have, a rural facility, and we have had openings for, an opening for a therapist for over 365 days. So, and, I have seen facilities where they can't even get a contractor in there. So again, yeah, I would say it's legit if it means the patient won't get any therapy if I don't provide telehealth. So yeah, I think with that, you have to look a little bit behind the scenes and see, are we doing this just because we don't want someone in there, or are we doing it because we can't get someone in there?
Mhm.
Okay. I am licensed in Virginia. If I go out of state, may I still complete an evaluation for a patient in Virginia when I am not in the state?
So you would just want to go back and check in the Practice Act to make sure there's nothing that precludes the clinician from being outside of the boundaries of that state. And again, I mentioned this at the beginning. Some states, the patient, it's about the location of the patient for many states. So if the patient's in state X, I just need to be licensed in state X and it doesn't matter where I am. But there are some states that do say you have to be within the state boundaries where the patient resides is during that treatment session. So just check your Practice Act.
And it's different for all three disciplines too, or it can be. So that's why we really hesitate to tell you, because I have Virginia, but I hesitate to say the best thing you can do to protect your license is to check yourself with the state board.
Mhm. And Shyla, did you say that was the final question?
We have one more. It says in Net Health Progress Notes, we have a new question introduced. Why only a skilled therapist is necessary for treatment/sessions, and how do we justify this when a helper or other individual can do the treatments?
Well, the helper is just following through and helping. The third party payer pays for our mind. What are we assessing? They're not paying for me really using my hands. What am I assessing? And then I develop a treatment plan, and then I adjust and progress that treatment plan. That's what the skilled intervention is for. So whether I'm doing it over audio visual or in person, it's still skilled. The helper is just simply helping.
Because remember, your CNAs, nursing staff walk patients all the time. PTs and PTAs walk patients all the time. What's the difference? It's just like Janet said, and it's for all disciplines. It's really about your clinical analysis. What are you assessing about the patient? And then what are you going to do about it as far as an intervention, a new intervention or new technique?
Good point. Shyla, thank you for watching the chat during our WebEx today. And I know we just have a minute left, and maybe I can just see if the panel members have any closing comments they'd like to make before we end today's webinar.
I have a question. Are CEUs attached for this event?
No CEUs for this event. This is hopefully informative and something that you'll find valuable just in your own practice.
As a closing remark, I just want to reiterate what I think Stephanie and Ryan both said, is this is something you got to just jump in with both feet and do it and try it. Now, that's not to say that you can't go to the APTA or the other websites and see what information you can glean and talk to other people that have done it, but you're never going to learn how to do it if you don't just jump in and give it a try. And it will be okay.
And we have many, many colleagues who need our help. And the situation that I'm in, I'm going into facilities that are strapped for labor, and they don't have therapists, and they appreciate our help. And if anybody asks you, are you willing to do telehealth to fill in for a therapist who's out with COVID or whatever, just do it, and you might learn to really like it.
And I would just say, again, be open-minded and allow yourself grace. Personally, I can say that some of my most fulfilling moments as a therapist in over 24 years have come through some telehealth visits. I've expanded my knowledge, my clinical skill set, my eyes to clinically analyze things differently. So it's been a very valuable and meaningful experience for me. And honestly, it's one I wouldn't trade for anything.
Mm-hmm.
Agree.
Well, Right at time, Stephanie, Ryan, Janice, thank you guys so much as our panel members today. Shyla, thank you so much for facilitating the chat. And for all of you that attended today's WebEx, we hope that you have found today's information valuable and will be effective in telehealth sessions with your patients. Thanks, everybody. Take care and have a good night.
Bye.
Bye.
Thank you.